Welcome everybody. As always, we'll give everyone a few minutes to join before we get started with today's Lunch and Learn. So I will be quiet for a little bit, but while I am and you guys are joining, please consider writing who you are, where you're calling from, and if you have any questions that you want us to address or answer today, that would be a great time to start putting them right here in the right-hand pane under the comment section. So we'll give everyone just a few minutes and then we will get started as always. All right, so I am going to hop in with some general announcements. So today is the last Lunch and Learn that I'm going to be leading until I take a little bit of a hiatus. So I've shared with a lot of you guys that I'll be taking a break until about July. And so Chris Tronson and amazing advocates will be taking over the Lunch and Learn and other series. So this is my last one, which is bittersweet, but also exciting because I know you guys are in good hands and you'll get some great new perspectives while I'm taking a little bit of a breather. Hi, Stephanie. Thank you for joining. For anyone else who's joining, please let us know who you are and where you're calling or joining in from today. So as always, we'll go through a couple updates. So the Lunch and Learns are really an opportunity for us to discuss education, for us to discuss content, and for us to give professional feedback the best of our ability. It is not intended, and these webinars are not intended to replace therapy. So if you are asking personal treatment questions or you have something that's specific to you, we're often going to refer or defer to a clinician that's local and in your area so that we're not getting into specific treatment questions, but instead we're answering broad-based educational questions to the best of our ability. This is not a crisis hotline. IOCDF is not who you should reach out to if you're in crisis. Instead, if you are feeling like you're in crisis, you're suicidal or unsafe, please go to your local emergency room, call 911, or call the suicide prevention line at 1-800-273-8255 if you're in the U.S. If you're outside of the U.S., please follow your local emergency services and contact information through them. As always, we have a couple of updates, so please make sure you visit iocdf.org/peace of mind. This landing page is where you're going to hear about all the upcoming programming, all the things that we're up to, but also opportunities for you to engage and help our community better expand. So right now we're continuing to collect research and information for our faith-based conference that's coming up, our faith-based initiatives, as well as anxiety in athletes. We're doing a survey on that. So you can find all of this information through this link below and be able to complete some important surveys for us to collect good information to be able to better serve you. As always, our first ever faith-based conference is coming up in just about a month, so in May, and we are excited to have this. It is going to be an amazing conference that's open to any faith-based leaders, anyone in the community, and it's really an opportunity for us to better educate faith-based communities on OCD and anxiety. So visit iocdf.org/faith conference for more information to sign up, or of course to encourage others to do so. All right, so let's hop in. Today we are joined by Dr. Sally Winston. Thank you so much for joining us, Sally. Dr. Winston is a clinical psychologist who's been specializing in anxiety disorders and OCD for 4 decades. She's the founder and the executive director of Anxiety and Stress Disorders Institute of Maryland. She's an early advocate and master trainer in the field. She's received the inaugural Geraldine Ross Award of the ADAA, which is Anxiety Disorders Association of America, in 2011. She has co-written 3 books with Martin Seif: What Every Therapist Needs to Know About Anxiety Disorders, Overcoming Unwanted Intrusive Thoughts, which has thus far been translated into 7 languages, which is so amazing, and Needing to Know for Sure about compulsive checking and reassurance seeking. They also write a blog for psychologytoday.com called Living with a Sticky Mind. Before the pandemic, Dr. Winston traveled regularly to deliver hundreds of workshops around the world, and they are both currently writing a new book on anticipatory anxiety and chronic indecisiveness. We know that all of your knowledge, all of your background not only serves the OCD community so greatly, but today will be wonderful for us to get some extra insight here from you, and thank you so much for joining us today.
It's an honor. Thanks for inviting me.
As always, we're excited to have you here and excited to have a new perspective. So for those of you joining, if you have questions, today we're really focused on recovery. We're going to talk a lot about OCD and recovery, life and recovery, and what that means. And so if you have any questions in the topic or specific questions for Dr. Winston, please make sure that you put them in the comment box on the right-hand side so that we can address them live. So let's kind of hop in. And I think the first question, Dr. Winston, we talk a lot in these webinars about OCD, about ERP, about CBT. And so I think that the treatment is something that's been well addressed, but we're not always talking about what recovery looks like and what individuals with OCD can expect recovery to be. Somebody just said, how do you define recovery, right? And so let's start there. Like, what is recovery and what can people expect when they think of recovery living with OCD?
That's a great starting place. And it's actually where I start with patients probably the very first time that I see them. My own view of recovery is influenced by my first teacher, who was Claire Weeks, back in the 1960s and 70s, when we were still in DSM-2. And there wasn't any panic disorder or OCD even defined. Dr. Weeks developed a way of thinking about anxiety and OCD, which influenced me profoundly. And I don't know, I'm always sad to hear that other people have never heard of her, because she really came up with a view of how to treat and deal with anxiety and OCD that predated ACT by decades. And probably the most influential thing she said in her about recovery was that recovery occurs when the symptoms no longer matter. Not when they no longer happen, but when they no longer matter. And that's the way I like to view about it. So given that people with OCD have sticky minds and they are going to intermittently go through periods of time when stuff crops up, is that recovery is a change in your relationship with those things that crop up. So they don't derail you, they don't send you into avoidance, you don't start compulsing, you don't get demoralized. It's just part of the fluctuations in sensitization that happen over the course of a lifetime. And your relationship with those things they don't bully you or get you in a bad place. You expect that kind of thing to happen. Sometimes it happens a lot. Sometimes it doesn't happen at all, even for 10 years. But when symptoms do crop up, when an intrusive thought pops in or a sudden urge to go do some compulsion that you haven't done for a long time, those things don't get in your way, and because they're not important, they don't matter. You've got them in their place in your sticky mind. And that's how I think about recovery. I don't think about it as a sort of number of things you check off on the Y box, or number of times that you do this, that, or the other. I think it's really a much more profound thing where you have changed your relationship with OCD and really with the experiences of your mind. And that's how I think.
I love that.
In the early days, there's a lot of stuff about cure, which I was very unhappy with. I didn't like that idea.
We still hear it sometimes, right? It hasn't totally gone away, but I love the definition. And I think that, it really is, it's about how the relationship, the understanding, and the impact that OCD and our intrusive thoughts have on our life shifts, right? And when we're in recovery, it should look very different. One of the things I do talk a lot about, I was just speaking about it a second ago with IOCDF staff, is also this understanding that you can have an OCD diagnosis and have an amazing life. And I think a lot of times for those of us, especially when we're in the middle of the struggle, that feels so foreign, and it feels so far away that sometimes we start to accept a life of suffering, and we start to kind of accept that, because I have OCD, I'm always going to have to struggle, and it's always going to have this really negative impact. But recovery to me is also, it's about management, right? It's about learning that like I can learn to manage my OCD and live an amazing life. Does it mean I'll never have a trigger or never have a struggle? Of course not. But the relationship with those triggers and struggles should be so different than they are before we get appropriate treatment.
Well, and that's how I think about it too, because I think the target for treatment should be suffering, not symptoms. And if you can zoom back and look at it that way, then recovery is when you don't suffer.
Love that. Yeah, that makes total sense. And I think that's a really great perspective and a shift for us to have on it. So when we think about treatment, we know that treatment is different for everybody, and the level of treatment or what treatment might look like differs depending on OCD, depending on severity, and also depending on comorbid diagnoses that someone might live with, right? Do they also deal with high levels of depression or, an eating disorder? And of course, treatment is going to shift. But I'm curious if you can define a little bit for our audience, just the different levels of treatment and the different ways treatment might manifest for someone to get to a level of recovery.
Levels of treatment, by that you mean intensity of treatment?
Yeah, just how treatment might look different depending on each individual.
I mean, there are people who really need to go into a residential or intensive type of environment. That's not something that I have done a lot of. There are people who need to be in regular psychotherapy for a long period of time. There are people who can have a short course of CBT that's specific for OCD, not any sort of CBT. And that pick up the general principles and understand what's going on and sort of grasp a whole paradigm shift in their life, and they're done quite quickly. I've even had people who came in one time and were tortured by some thought, and I explained it, and that was the end of their treatment. So it really varies tremendously from person to person, and recovery, getting to recovery can be any number of different ways. And there are people, I think, who pick up self-help books and get it,
Yeah. And treatment really, I think the important piece is there's no rule book, there's no guideline, right? It's what works for you. And I think the thing that I always want to reiterate is even in a facility like ours, right, where I run a residential support program here in Houston, or whether you're at an outpatient center, each patient is treated on an individual basis. And so while treatment may look similar and we may use a lot of the kind of core concepts across the board, each person's treatment, each person's path to treatment, and each person's outcomes are different. And that's actually a beautiful thing, because you wouldn't want us to only do standardized treatment for every single person, because it has to be individualized, right? We all have different needs. And I talk a lot openly about how I still go to therapy every Wednesday morning. I had treatment this morning. I see my therapist at 7:40 a.m. And I'm probably not at a place where I need to be like, I have to have therapy every week to manage my OCD, but it works for me. I enjoy it. It's accountability, but it's also time for me to work on family dynamics and other things, that relationships and stuff that like I can always be working on. And it's not, I don't look at it as, oh, I have to be in treatment, and it's this thing that like, if I don't do it, I can't manage my symptoms. But instead, like, I choose to be in treatment, and I choose to still continue to work on things that can be useful.
Well, yes, and very often during that period of recovery, when you're not suffering that much, there are things that sensitize you or make the level of intensity of your intrusive thoughts or whatever your symptoms are worse or better. And learning to recognize those patterns and work on those issues, is part of recovery as well. And a lot of times patients have been through pretty intensive evidence-based or evidence-informed kinds of ERP-ish treatments. Really, they've got that part, but it's the ups and downs of the intermittent nature of sensitization that is very important. So being able to recognize when you're sensitized, what it's about. It's rarely anything about the content of whatever your OCD is about. It's usually something else. if you're chronically mad at your boss, you're going to end up with more urges to wash your hands. But it's got nothing to do with hand washing. It's got to do with arousal, which then will pick up, if you're a migraine person, you'll get a migraine. If you're a, hives person, you'll get hives. If you're an OCD person, you might get OCD symptoms. But the ongoing treatment is really about the sensitizing factors, and also to keep a look at all of the various ways in which OCD is maintained, and to keep an eye on it. Because the way I look at it, the maintenance factors about OCD are the things that are the targets of treatment and treatment during a recovery period. So that for me, the way I like to put it are sticky mind, which is the sort of the biological piece of it, entanglement, which is paying too much attention to content and getting all fused with thoughts and getting all caught up in stuff you don't need to be caught up in. This concept of paradoxical effort, which is that sort of struggling, trying too hard, working at it with intensity, white knuckling kind of work. And avoidance, and the big one being, of course, avoidance. And being able to pick up and notice when you're doing subtle avoidance things, or when you've gotten entangled with your thoughts in a way, or when any of those things have popped up, to be able to just take notice of that and then step back and be able to see, okay, why am I so sensitized? What's going on? And and to work from there in your therapy. And that may very well not be ERP at all.
Right, absolutely. How do you encourage and equip your clients to maintain their progress? So once someone's done their therapy, they've learned how to live with uncertainty and how to manage their symptoms. What are some of the best things you do, or ways that you encourage them to continue to maintain that throughout their life?
Well, it's a great question. And again, very different for each person, right? Just what you said before. One thing just to be aware of is that I don't think about termination. The old psychoanalytic concept of, think of me as dead termination and let's grieve. It's more a matter of stretching out appointments, making appointments be less frequent, and then maybe as needed, or check-ins, or something where you maintain the relationship, but you may not see the person who's your therapist. Just like you don't terminate with your dentist. They're still your dentist, even when you may not see them, unless you have a problem. So it's a flexibility in that relationship, and always feeling like there's no shame in going back or asking for an appointment or wanting to discuss something, whether it's OCD in particular or some sensitizing issue that's come up. So I think about it, in a flexible way. There are some things that I think are helpful in terms of recovery, and one of them is dealing with family, environment, the people around you, dealing with your relationship with them with respect to your OCD. And I think very often people are secretive. In the early part of their treatment, they're ashamed of what they're going through. They don't talk about it. But being able to disclose to safe people who are going to understand once you explain what's going on, so they cannot accommodate, so that they cannot reassure, so they can participate in helping you to stay on track. That's really important, and it has to be done sensitively and carefully, and not with somebody who's going to shame you or do all the wrong things. But I think opening up and disclosing to the right people can be very, very helpful.
Definitely. A healthy support system is critical, and really I think that support system is critical, and really I think that, sorry, I'm got an echo for a second. But I think that the more we can focus on effective treatment and including those that we trust, those that can support us, the better our outcomes will be. And the thing I always say that I think is important to add in as well is that the biggest piece of recovery that is critical for us is to ensure that we become our own therapist, right? We have to remember that at the end of the day, our providers can be amazing. They can be great. They can encourage us. But what we know is that our providers are only with us a certain amount of time, right? We only get a certain limited amount of space with them in session. And a lot of the work that we do is outside of sessions, and it's work that we have to do on our own. And so the best providers, right, teach you to be your own provider and remind you that these skills, while you learn them in a certain environment, they're skills that you get to keep for the rest of your life and use anytime you have a trigger. And I apologize, Sally, I think we're hearing a little bit of an echo and maybe some connectivity issues as well. So I will mute myself as we ask questions, and then when each other talk, we may have to do that to help out. But how, one of the questions I just started to talk a little bit about is preparing clients for ERP across all subtypes. And I speak a lot about the importance of this is why uncertainty and the concept of uncertainty is so critical that we understand. It's because we have to know when I get a new trigger, when I get a new intrusive thought or something that I haven't necessarily dealt with, we want to make sure the core concept of uncertainty is understood and that patients know how to lean into that versus thinking, oh, well, I've never done this type of OCD treatment before, so I don't have the tools. You have the tools, they just look a little bit different. But can you talk a little bit about that, of how to transition ERP to different subtypes?
Modify a little bit from my perspective. I don't usually think of think in terms of tools. I think in terms of a shift in attitude and a shift in perspective that involves a willingness to be open to things like doubts, uncertainty, new experiences, waiting around where you don't know what's happening. And I like to talk about it in terms of an attitudinal shift rather than a toolkit, because I think it's very easy to turn any tool into a compulsion. And it's really not about what to do. It's about how to be in the presence of uncertainty or discomfort or distress or the urge to compulse. And anything that you do when you're coping can be turned around if it's used in a intentional way. So let me see if I can give an example to be a little more clear about what I'm saying. If this, and you're having a thought that you would prefer not to be having, there are two ways to turn on the radio. One of them is to turn on the radio so that while your mind is having this crazy thing going on channel 1, you can also be listening to music. Or you can turn on the radio in order to stop that thought from bothering you or make it go away or banish it or struggle with it, and to make a competition between the radio and your mind. And what I think is most important as you prepare for ERP is to understand that willingness, that openness, that it is not in order to get rid of, but it's while. And that your mind will fix itself if you stop interfering. If you stop trying so hard. So a lot of learning how to allow, how to accept, how to be while something is going on that you would just prefer not to have it going on. Does that make any sense, how I'm talking about
Totally, yeah. Yeah, I love it, right? Is really also, I think there's this big component that we focus a lot on for ERP as well, of values-based living, right? Like the noise isn't always going to be gone, but how can we continue to choose to live by our values while the noise might be there? And knowing that that's also a big piece of recovery and, continuing to choose the life we want versus figuring out how to fix or address OCD. So a couple questions that were brought up that I'll touch base on. So Kelly at 1103, while doing ERP, what do you think we should look for? And if you don't mind, Sally, if you can mute yourself, I think we're getting an echo. There we go. Chelsea did it for us, so that's great. While doing ERP, what do you think we should look for in a good therapist? Things to make sure we look for that we're getting the best care. So I think overall, Kelly, what I would say for this is it's really about, are they able to, first of all, do they specialize and understand ERP and OCD treatment, right? That's first and foremost. Have they been trained and do they understand OCD, or are they just using broad-based CBT? That's really critical. But the second is, have we started to identify what our core fears are? Do we understand the concept of uncertainty? And are we slowly and systematically working to address those fears? The way we address the fears is by learning to not respond to them, by learning to sit with the anxiety in a slow, systematic way. I always say in 12 to 16 sessions, we should start to see progress. But really, it's when you're with the right provider, sometimes I always say you kind of just know, right? Like it's like, oh, they get it. The things that they're saying make sense to me and I can understand why this is useful. Sometimes at the beginning, we don't understand it. We don't want to do it because it's hard. But it should work and we should see really good outcomes. And as we slowly start to see, oh, this makes sense, that's when it tends to click and when we start to see great progress. Happy to hear for some of you that self-help books continue to be a great part of what you do. So definitely there's so much between self-help books, workbooks, apps, you name it, and ways that you can engage in treatment that way. Mario, today we're not going to focus on TMS, but I did a webinar recently with Dr. Wayne Goodman, and I recommend that you go to iocdf.org/peace of mind to watch the webinar with Dr. Goodman where he talks about medical treatment and interventions for OCD. Kevin, thank you. I appreciate your comment because I do think, one of the things Kevin said is appreciating that OCD isn't in a vacuum. And it's true, right? Those of us who live with a mental health condition, even if OCD is our primary diagnosis, we still have family, we still have life, we still have stress, we still have other things that happen. And sometimes while OCD treatment is specific and that's more focused on OCD, supportive treatment and other interventions can be really useful depending on what we're dealing with or going through in our life at the time. A question from Debbie for you, Sally, is how do you challenge a perfectionist with intrusive thoughts? How do you let people know that it's okay to not be okay, to let it go, and to move as you can get into having intrusive thoughts and judging your intrusive thoughts? How do we help those learn to know that they are okay after already getting treatment? So I think really the overall question is, how do you challenge a perfectionist with intrusive thoughts and allow them to let it go and move on despite their anxiety for things to be perfect?
Very difficult question because people with prominent perfectionism really are difficult sometimes. I think the first thing is to understand intrusive thoughts for real, not as something that you have to get rid of, but as something you have to grasp what they are and what they are not. And the fact is that everyone has intrusive thoughts, and for most part, intrusive thoughts just pass, and we barely even remember that we had the intrusive thought. It's the intrusive thought that gets stuck that's the issue for a person who's a perfectionist, and it gets stuck by virtue of how much it is thought. So the fuel that keeps an intrusive thought going is the struggle against it. And to understand for the perfectionist that trying to clear your mind or make it pure or make it go away or have a mind free of intrusive thoughts is not a reasonable goal because everybody has them. It's to be able to treat an intrusive thought in a way that lets it pass instead of makes it stuck. The other piece is to understand what an intrusive thought is not. An intrusive thought is the opposite of a wish. Because the only thing that gets stuck is the thing you fight. It's the thing that's the opposite of you. It's the thing that is the most repulsive or the most disgusting, or according to your particular value system, is the thing you most don't want to be thinking. So you never find somebody who is afraid of jumping up in church and yelling, some blaspheme thing. You never find that in an atheist because they don't care. But in people who have harming obsessions, for example, and who want to be perfectly never have such bad thoughts, the problem is going to be that if they see those thoughts as somehow meaning something, they're going to struggle against it. If they understand that only gentle people who are repulsed and hate the idea of harming, those are the people who fight. So for a perfectionist, learning that you cannot have a pure mind, but that it doesn't matter that you don't, you have to go through a very, very clear explanation of what an intrusive thought is and what it isn't, so that they can be free to lean into it and to be willing to have it.
Totally agree. And I love
continue to see. So that's the first step. The second step is to be dealing with perfectionism in general, which is usually an outcropping of some very deeply held values about responsibility, or about caring for people, or about being the sort of person that you want to be, but with some considerable distortions, and inflexibility. And the opposite of being a perfectionist is not to be sloppy, it's to be excellent. And so to be able to sort of work with the concept of perfectionism in general, then that will slide over into your work with the thoughts.
Totally agree. And I think that the core concept here is really about accepting uncertainty and not trying to make things perfect or in accordance with OCD and OCD rules, right? The more we fight it, as Dr. Winston's talking about, the more we get stuck trying to appease OCD or trying to make it okay or be certain or be sure, that is when we're in this never-ending battle, because we never really can achieve that. And that's when it gets total hold of us, versus being able to live in the middle ground, being able to accept uncertainty, accepting imperfection. And actually, when we do that, we become better at things, because, the strive for perfection is never ending. It's continuous. So a couple other questions that we had is, Josh asked, how do I feel about humor to cope with intrusive thoughts? And I think that, I think this is something that I actually really appreciate humor. And I think that it can be really useful for people to use humor in an appropriate way. I think it can be harmful when it's other individuals using humor for someone else's OCD. So it's really about if it's for your own and it's something that you're comfortable and you've set appropriate boundaries that around with family members, I think it can be okay. But I think if you're not the person with OCD, using humor for someone else's could be hurtful, just because obviously they don't enjoy it. They don't find it funny. So it's that balance. What happens if it's not just a bad thought, but it's dictating what you should and shouldn't do, such as putting on deodorant this amount of times, cleaning this, cleaning that, and it's not a harmful thought? So again, in this case, Debbie, we'd really want to lean into ERP. We'd want to lean into uncertainty around the OCD there, right? So it may not be a bad thought, but it's more of, I have to do it this amount of times. We're following OCD rules, OCD rigidity. And the more we do that, the more stuck we get. So as Dr. Winston mentioned, that I love, it's about the fight, right? When these thoughts come up, are we fighting them, and are we trying to appease them, and are we trying to solve them, or are we letting them be and moving on? Because that's where freedom actually exists. Overall, one of the things that I heard you say so many times today that I loved about recovery is that it's about the suffering, not the symptoms, and really us identifying how we're going to shift that suffering, right? Because the symptoms may still be there. And this is actually a really important thing for us to talk about, is a lot of people say, oh, treatment means I won't have OCD, or I won't have anxiety, or I won't ever have an intrusive thought. We can't make that happen, right? I can't make intrusive thoughts go away forever. I can't make you never have anxiety. but we can change our relationship with the intrusive thoughts. We can change our relationship and the suffering that the thoughts bring and that our OCD has. And so that's just been an amazing takeaway. Overall, I think we've learned so much today about management and what it looks like and how we can learn and choose to live an amazing life despite our diagnosis. I also love the dentist analogy, right? That you can only need to go to the dentist every 6 months, but guess what? If you have a cavity and it hurts, you need to pick it up, and you probably need to call that dentist and not wait for that 6-month appointment. OCD treatment and mental health treatment's no different, right? This is our brain. And if things are sticking and we're struggling and we need to address it, pick up the phone and call versus waiting, because that's where the benefit will truly lie versus waiting until we're in a relapse. Thank you so much for your time today, Dr. Winston. It's been amazing, and we've learned so much about recovery, the path to recovery, and how we can maintain that. Any final thoughts for you as we wrap up that you want the OCD community to know about recovery and OCD?
Well, thank you for having me. The one piece that I think I didn't mention at all, which I think it happens with a lot of people, is that during the early part of OCD treatment, you're just working on your ERP or your understanding, or you're trying to figure out which is the obsession and which is the compulsion, and just working your way through. But I think once you are substantially better and you're not suffering so much, something else will often happen, at least for a while, and that is a kind of a grief and sometimes even an anger about all the wasted time before you got the help that you needed, before you understood what was happening. There's a kind of a wave of feeling that I think is very natural and needs to be just gone through, which is about, it comes with the relief, but it also comes with looking back on and grieving for yourself and whatever suffering you went through before you got the help. And I just wanted to mention that because it happens a lot.
100%. And my final feedback for everyone today is that when you think about recovery, I want us to imagine an amazing life where presence and joy are feasible and where we don't have to accept a life of suffering. And so my ending message, as well as Dr. Winston's, I know, is that recovery is possible and help and hope are always available. Thank you, everyone, for joining today. And I will see you next week on my final Live with Liz before my brief hiatus. Thank you, Dr. Winston, for your time.